we started to do MMA embolizations after visiting the Val d'Isère conference in 2019 actually, where the guys from the US first presented results from the first, I can't remember, but around about 100 patients with pretty impressive results. And from the beginning it seems to be a logical approach and an approach with a low risk. And so we were initially interested to try it out. Back home, we immediately started to talk to our neurosurgical colleagues. They were skeptical in the beginning, but as it is an intervention with a low-risk profile, we were able to convince them to try it out for certain cases in the beginning. Then it didn't really take long also for them to see that we didn't have any complications in these interventions, and that was, I think, the main clue to start more and more doing it for nearly every patient now. Because the other side, to really measure the effect of this treatment, is much more difficult. So I think the key was first to show that it's not dangerous for the patients. When we started with MMA embolization, we initially took the same technique that we use for nosebleeds, for example. So we started to use particles and coils for embolization. Main reason was that the patients were under local anesthesia, often old patients, not very stable patients. So we decided to use this approach, good experiences with that. And this is why we're still doing it. Liquid embolics are interesting, we have some good data on it, but it needs general anesthesia, and we're not absolutely sure whether it's more effective or not, so we stay with particles at the moment. Well, the SwiftPAC coil for this indication is something completely new. I didn't use detachable coils until now because that would have made the procedure very long, very complicated. From my understanding, it would have been necessary to navigate to different branches of the MMA and to deploy coils there. Lots of coils possibly, due to the fact that there are more than 3 vessels sometimes. And because we do not know whether it's necessary or not to just coil the distal parts or go all the way down, detachable coils were not a good choice for me until now. We used pushable coils, as I mentioned before, just to add an additional block in the proximal part of the MMA, but not as a standalone treatment. So with SwiftPAC, that changed because the coil is thought to cover a long distance and more than one branch with one coil. An idea that is interesting because with that you're able to start in one branch and then come down to a bifurcation and then treat the next branch with the same coil, and in the end, with 1 or 2 coils, you can often cover the whole MMA territory. Of course, a coil does not have the same deep penetration like liquid embolics or particles have, but at the moment we do not know whether that is necessary or not. An interesting question for the future. So when we assume that the treatment with coils alone, like with SwiftPAC, is effective, or nearly as effective as using particles or liquid embolics, then the safety aspect is an important point, because I think it has the highest safety. With particles, you can lose particles if you're unlucky or not aware of your collaterals. You can lose particles into the orbit. With liquid embolics, you can lose embolic agent to smaller branches where you don't want to have it. So it's much more important to have a very good view, a patient that's not moving, to have at any moment a good understanding where your embolic agent is going to. With the coil, it's a different story because you can retrieve it at any time if necessary. You can place this, you can clearly see where it goes, you can correct the position if you're not happy with it. So from the safety aspect, I would say I wouldn't fear to do any harm with such a coil, and without having any data, I would expect it is safer than using other embolics. On the other hand, we do not have complications and not much complications with other embolic agents, so the question is maybe not that important, but yeah. The SwiftPAC coil seems to be a good choice for using small catheters, but in the same time filling a large volume. So it's a very long coil that you can easily use to very small catheters, and that is interesting also for some aneurysms, especially when it comes to filling of aneurysms with a larger volume. I can imagine that we can use this also for embolisation of durafistulas from the venous side, for example, vessel occlusions, so there are options. I think especially always when it comes to very distal locations that have a larger volume anyhow, then the coil can be interesting. But in general, I don't know yet. I haven't used it in aneurysms, so I'm excited to do that one day, but this is what I think where it might be useful in. Yeah.